Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is sexual health in cancer care. And our guest is Erin Sullivan Wagner. Welcome, Erin.
Thank you. Thank you for having me.
So here's a weird and unusual fact. Erin and I went to high school together, and we weren't in the same class, but the same town in South Dakota. And we reconnected around cancer care.
Yes.
What about 6, 7, 10
10
years ago?
10 years ago. Yeah.
Yes.
I think so. I think it was close. It was at one of your presentations of Above and Beyond and one of your trips. And it was really inspirational, as I recall. And I was just in line to say hello and introduce myself and just actually tell you what a great presentation it was. But during the presentation, you had said you had gone to South Dakota State University, Jackrabbits. And so, that was so close to my hometown. So quickly looked at your name again.
And go, wait, I think I know that.
Wait a minute, I know a Deming. Anyway, so then stood in line and said, "Are you from Madison, South Dakota?" And he said, "Yes." And I said, "Oh my gosh, you're Dick Deming."
Yes, that's been my name. So her brother, Erin's brother, was in my class, and we know lots of family members. And so my first question is, where did you grow up? But I know the answer to that. Yeah. So tell us about Madison, South Dakota, for those who don't know.
Yeah, Madison, South Dakota. It is a small town outside of Sioux Falls, probably 45 minutes from Sioux Falls. People recognize the name of that town, but probably 7,000 total population. So
I always say 5,000, but
and he's not taking into consideration there was a 4-year college there, and there were probably close to 1,000 students there.
There you go.
And Dick, his family lived about 4 or 5 blocks from me.
Yes. And obviously just one high school. And so what was your claim to fame in high school?
Do you feel like you know the answer?
No, I don't know. You could say whatever you want. Somebody might try to check on it. But
yeah. Okay. I was a student body president. I ran against your sister.
Oh, really? For student body president. Awesome. Well, that's, And was that your senior year?
Yeah.
Senior year. Awesome. And what did you run on? What was your platform?
That's such a silly question. So the year before, when I was a junior.
World Peace?
No, it was way bigger than that. It was, we were told we were going to have to, because Mitchell had such bad fans, we were going to move, the basketball team was going to move to the visitors side of the auditorium, and we were going to move to the visitors, and we were going to have to cheer in this little corner. And it was such a big deal.
Because it was such, the fans of Mitchell versus Madison. The fans
behind our players would be, they would spit on the player. There was all this fear.
Because the Mitchell fans were over there. So we were going to move the Mitchell fans.
So we were moving everybody.
So anyway, you were running on the platform.
So I pushed back and said, we are not moving to the other side. Of course, it was really self-serving because we didn't think the cheerleaders could all fit in that corner.
Were you a cheerleader also?
Yeah.
Yes,
and so I ran on. What happened was we fought back and got them to reverse the decision. And of course, the student body was behind it. And so I ran on that platform. See what I did for you last year?
Yeah, you're right. That was much more important than world peace.
Yeah, it was way bigger at the time.
Well, good. So then what did you do when you graduated from high school?
I came to the University of Iowa and graduated in marketing.
The University of Iowa?
My sister had come here in physical therapy. And so, when you're from Madison, South Dakota, it's a great place to be from, but you want to go somewhere else. Yeah. And so
that's a long ways, the University of Iowa.
Yeah.
And did you know what you wanted to major in?
No. No.
What was your first, when you showed up?
I thought I was going to be a lawyer.
Okay.
Then I didn't pass
You've
that
been student
class.
body president. How about politics? Did you think?
No, I don't know.
No?
No,
Okay.
I didn't know.
Okay.
So I
and then what did you
marketing.
What did you graduate in marketing. And
Business.
what was your first job outside of college once you got out of college?
Well, actually, I worked at McDonald's for 3 weeks while I was interviewing, but I sold office equipment so Canon copiers
Okay.
for an office
Okay.
equipment dealer, and stayed in the office equipment industry for 20 some years.
Now, Erin, besides being a former student body president in Madison, South Dakota, is the recipient of the Above and Beyond Cancer Award for what she has done in elevating cancer care as a cancer survivor. So next, why don't you tell us a little bit about your cancer journey, because it was really your cancer journey that led you to really get involved in the body of work you're involved in now.
Absolutely. In 2008, I was diagnosed with anal cancer. And that was, as you can imagine, a devastating diagnosis, as every cancer diagnosis is. But I didn't know anything about anal cancer, and we didn't use that word. Anal wasn't a word that's used very often. So it was a really uncomfortable topic. And so that in and of itself was an interesting journey to go through with kids that were in middle school and high school. But I was diagnosed, and it was stage 1. So I really felt like it was survivable cancer, and it wouldn't need to have a devastating ending, and did pretty well through it. I did chemo and radiation for 5 weeks. And of course, that's really a tough area of the body to have radiated for 5 weeks, but did pretty well. And I went into life coaching and did a lot of coaching with patients afterwards. And while that was going on, I was struggling with the sexual health side effects that I had from the pelvic radiation. And the interesting thing for me was that I was told I would have no sexual health side effects from the treatment. And even though it was listed as a side effect of the treatment, when I asked about it, they were like, no, you're not going to have issues because you're young and you're healthy and you're sexually active. And I was 49 and I was married, and I had cancer. So, but they said young, healthy, and sexually active, though they hadn't asked if I was sexually active. So all of that I found so interesting to be so sure. I was told 3 times by 3 different providers that I wouldn't have issues with sexual health because I wasn't having internal radiation rods. And so all would be good. So at the end of treatment, when you're told you don't have cancer, no residual tumor, the elation is just so over the top of I've got my life back, and all is good. No matter what is next, all is good. And then eventually you go back to your life and you want as much of it to be as whole as possible. And 6 weeks after my treatment, we were told that I was healed enough and that we could resume sexual activity, penetrative sex being one of them. One of the things that, of course, we had asked about. And when we attempted intercourse, it was so terribly painful, really so severe and urgent immediately that, of course, we stopped, and I must not be healed, and I don't know what's wrong, but this is bad. And so, of course, went back and asked about it, and they just had never heard of this, And that was concerning to me too, because then as a patient, when your physician, your providers never have heard of this, then you feel like, okay, we're doing something wrong, or I'm doing something wrong, or I must not be healed yet. And they referred me then, that was the medical oncologist, referred me to the radiation oncologist. I went through a series of referral to figure out what was going on. And the real tough part of this too is that there was no way to explain for sure what was happening except to be able to say how you feel. So I would say, I feel like he is hitting a wall. That's what it feels like. And when that didn't, they were trying to figure out if that would be scar tissue. I said, it feels like he is thrusting through my skin. where there is no opening to thrust through. That's the feeling. And he would say, I have not penetrated. There's no insertion. Why? I don't understand. I think she thinks there is. There isn't. So without a camera, all we could do was, as best we could, describe how this feels. And from that, then they tried to diagnose what is the issue. And when I was eventually evaluated with a pelvic exam, which now is 5 to 6 months after my treatment. So I've gone a long time with no evaluation. And my gynecologist said, well, you do have scar tissue all the way up and down the vagina. So maybe that is what's happening, is he's hitting that scar tissue. And he was like, there's no way that, but that made some sense, right? That's a wall. So went through a procedure to have that removed. And of course was told, use it or lose it with scar tissue. And so we tried very hard to have intercourse, and we were told to use just oil to go slow. But the pain was so severe, so immediate every time that there was just no way. And it got to the point where he would say, I can't do this with the look on your face, and I can't do this just to be the source of the pain. There's nothing arousing about this. And so we started to develop other issues within the relationship that we didn't have when all of this started. It just complicated it. We didn't necessarily have a format where we were communicating well about it. He had heard over and over that they've never heard of this. He believed that maybe it was trauma to me, but maybe it was in my mind and not truly happening every time, the pain. And that created quite a wall between us as a couple. And we searched for treatments, tried everything for years. But because I hadn't been treated for 6 months, what had happened was the scar tissue around the hymenal ring had built up too thick to make a difference when I was finally evaluated, when they finally figured it out. I needed to have had dilator tools, and I needed estrogen. I needed an evaluation. I needed to have pelvic floor therapy. I needed to have seen a gynecologist. All of those things I needed and didn't have.
And the sad thing is that it's well known that radiation to the pelvis causes issues with the vagina, with lubrication, with all of those things, and that the best way to have healthy sexual functioning is to address it, right away, not after all the scarring has taken place. So it's, and when obviously you've learned all of that, and you look back, even as I'm hearing you tell the story, how, well, you're not going to have any sexual dysfunction. That doesn't happen. When really, if a doctor asks a patient, are you having any issues with sexual function, they will find out. But if the patient doesn't volunteer it on the follow-up visit, and the doctor doesn't ask it on the follow-up visit, everyone just said, well, and nobody ever mentions it. It must be that it's not a problem.
For sure, that's true. And that it's interesting that it is listed as a side effect on radiation treatment from the manufacturer of the machines. And so it's so interesting to say that there won't be an issue when it's listed as a side effect, is why it was even asked about. But probably something that is the most important thing to think about is when a patient is diagnosed with cancer, it really is the fight on their mind. It is the only thing sometimes on their mind, and it's the focus, it's everything. So fighting cancer, even if they had said, you may have some sexual health issues we might have to deal with down the road, that would have been great, because I would have had an expectation that we could have talked about, but I wasn't dealing with it in the moment.
Right.
And And I don't want anybody to think that I think that it is up there with the focus of curing the cancer at the time of a diagnosis, because I don't, even though I do believe that it is important after the diagnosis for sexual health to be brought up, because it is we're curing cancer. You're curing cancer. We really are. With all of the advancements in treatment and technology, the survival rate goes up every year exponentially. People are living with the long-term side effects from their treatment.
Right.
And it's why it's
If
so
everyone
important.
died of their cancer, we wouldn't have long-term side effects.
That's
because
right.
People don't live long-term. So you're right that when is the right time? I mean, mentioning as you embark on treatment, most individuals that are going through treatment with chemo and radiation, most patients don't feel up for sexual intercourse during that time. But at the time that the treatment ends and you start on the healing path, that's kind of the right time to bring up, okay, you're cancer free. Here's some issues that I want you to be aware of, because this is a consequence of some of the late side effects that you might experience.
Absolutely. So I do think it needs to be brought up right away, just to set the expectation. And that is what national guidance would tell providers, is that it is something that should be brought up at the time of diagnosis. And just like you would for any treatment side effect, you would tell patients if they were going to have issues with bowel function, or if they were going to have any incontinence. You would tell the patient that, whether it seemed like it was important or appropriate in the moment because the cancer's bigger than all of that.
Difficulty swallowing.
Right.
All of those are so natural to talk about. And one of your points, which is so valid, is that talking about sexual function is not a normal thing that most patients and providers talk about.
Right. So we probably don't talk about it easily in our culture anyway, in a clinical setting, even less so. Again, why I think the onus is on the providers to talk to patients about this, because patients already are bargaining with God for their life. They're already trying to figure out what their priorities are. It isn't probably on the list of concerns. They need their providers to let them know about the quality of life side effects that are going to impact them.
Yes. And hence, you have taken your life journey, your journey through cancer, and what you experienced, and have, paid it forward by creating a not-for-profit that specifically looks to address the lack of providers' knowledge on how to have conversations with their patients about sexual function.
And the way that all started was I took life coach training, and I really didn't think that's what I was going to coach about, but I was going through all of this evaluations to figure out what was going on with me. And I was curious. And so when I would talk to patients, I would ask them too, have you had sexual health side effects from your treatment? And, really almost unanimously, people would speak to, even if it wasn't something that involved sexual function, it might be communication issues, or how they were feeling about their body, the weight gain, or just the loss of hair, the loss of a limb, just all those things that emotionally impact us. Almost everyone had something to say about that was an important topic that they hadn't talked about before. And because their providers hadn't talked to them before, I really felt like there was a need to go back to the oncology community and say, your patients want to know this. They need to know this. They need to know because their relationships actually depend on it, that they have some ability to dive into this conversation with some awareness about what can be expected. And their partners deserve to know. So I started working with people like you, actually. So providers that were treating patients for sexual health issues. So not just the oncologists, but gynecologists and urologists. I wanted to learn what are the issues that patients face that weeks or months or years down the road providers will be treating. And I learned what those issues were, and then we created a presentation and just went out to Oncology Nursing Society and said, this is what your patients want to know. And from that, they suggested that I apply for a grant. And from there, we just started developing educational materials for providers. And so those are the members of the care team on how to address sexual health and cancer care. At the time when we first started, I thought I could just say, you need to tell them what to expect. Just tell them what to expect. And I thought that would be an easy thing to do, but it wasn't. And part of it is because sexual health isn't so easy to talk about. When is the right time? The clinics are overburdened. Nobody's got extra time in the day. When do I bring this up? What if the patient has their 5-year-old son with them? What if there's a controlling spouse in the room? What if I don't know the answers to the questions they might have? What if I don't know where to send them? Am I really going to bring up this topic if I don't have any awareness around the topic? So what we found through these focus groups were that providers really didn't feel like they had adequate knowledge of what the side effects were, nor did they feel comfortable that they knew when and what to say in a message to the patients. So that's what we created our education around.
And so it really did focus on communication first and foremost. Obviously, from a provider side, the communicating is really important, but also having in your armamentarium, what do you do to try to help remedy various sexual dysfunctions? So that's a separate issue. That's a medical issue that we need to, through ongoing continuing education, take those classes, figure out, partner with other people in the community.
That's right.
As a radiation oncologist, I mean, I can be well aware of all of the potential side effects, and I can be aware of some of the things we do to try to prevent those, but I'm not going to be the most up to date on the various techniques that a gynecologist that functions in female sexual health might know. But I'm sure going to know who is the gynecologist in my health system that can be my ally and can be the person that will be the one that I'll refer patients to if their issues are greater than I know how to remedy.
That's right. So that is what you just described is the referral roadmap that we, in our workshops, we help providers establish a roadmap for their own clinic, their care teams, to know where will they send a patient for maybe emotional distress, maybe issues with a partner or the couple needs help together. So typically the common referral sources for sexual health concerns in patients will be gynecology and urology, pelvic floor therapy, and then of course the mental health counseling piece. So sex therapist or a mental health counselor, couples counseling. And then of course support groups and all of those things are important too, but we really encourage that there is a roadmap in every clinic, in every oncology clinic of where, because if you know where you can send your patient, you're a lot more apt to bring it up because you know where you're going to be able to get them help. So that referral roadmap is a real important piece of it.
Totally agree. I think it's so important. Let's repeat that. And again, your story was about a woman receiving treatment specifically to the pelvis, including the genitalia. But some of the sexual dysfunction, as you've already said, might be unrelated to actually treating genitalia, but just to having cancer in general, going through the body changes, or two other very common situations that affect sexual function would be women with breast cancer who often get thrown into early menopause, or even if they're in menopause, menopause is made worse by anti-estrogen therapy that affects sexual function. Or the opposite side of the coin would be men, predominantly prostate cancer patients, who either have surgery or are getting anti-testosterone therapy. So those are three very common situations: pelvic treatment that includes the genitalia, or breast cancer treatment that is anti-estrogen treatment, or prostate cancer treatment that's anti-testosterone. All of those will definitely affect sexual function. And so our referrals, number one, being aware of it and being open to talk about it. Because if you don't ever talk to your patient with breast cancer on anti-estrogen, or the man on anti-testosterone, and asking, are you able to get erections? Are you having any issues with sexual function? You'll never, most of the time, the men especially aren't going to bring it up.
That's right. And sometimes the best that we get to is sexual function. They get sexual function talked about, but we don't talk about the, the hot flashes and the lymphedema and the low libido, the things that aren't necessarily function, but they definitely go to how you feel as a sexual being and how really your efficacy as a sexual partner. And all of that is important too, and that changes the dynamic in a conversation with a partner. All of that is impacted by changes with sexual health side effects. All of that can change and cause you to be at a place that you've never been in a conversation and in this relationship. And most people need some help through that.
Right.
And the awareness that you might need help through that, given from the medical community, from a provider telling a couple that you might need help through that, normalizes that. That normalizes it for the patient and the partner. So you're not the odd one. This isn't ridiculous. You aren't being too greedy, asking for too much. You should just appreciate your life as it is, because the day you are given the clean bill of health, you swear that is all you're going to care about.
So let's talk a little bit more about your organization and what it does to training health providers. How do you get access to health providers to train them? So you present continuing medical education at conferences.
We do.
Do you get invited into health systems to help with the communication? Because unfortunately, if you have a medical meeting with doctors and you as a layperson are having a continuing medical education on talking to patients about sexual health, probably not going to get the doctors to rush into your session, because you're going to be competing with other sessions that they may.
That's right. And sometimes the doctors, we don't have that. They don't rush in anyway, because they're really hoping somebody else on the care team will handle
Can
this
the
topic.
nurse talk to the patient about it?
Yeah. And we actually agree with that. So just because I guess maybe our healthcare system suggests that the provider can, only has so much time with the patient. The oncologist for sure only has so much time. A few minutes really feels like it, sometimes 7 minutes with a patient. The care team, though, may have more time. And I'm not proposing that people take a lot of time on this topic. In fact, just the opposite. What our training, who our training targets, is the care team, really everybody but the oncologist. We need the oncologist support and backing on all of this, of course, but we aren't necessarily saying that this training belongs in their tool bag and they need to be doing it. It's great when we have providers like you that just naturally care about that whole person. But that isn't necessarily the case with everyone. So we target the training for the advanced practice providers and then the patient care team. And the training is so that we cannot disrupt clinic flow. I can't say that loud enough that
So the nurses, the nurse navigators, and nurse practitioners,
yes,
those are kind of the most natural part of the care team that
social
would have
workers sometimes,
Mhm.
just anybody that would talk to patients about side effects. If you would be one of those people that would talk to a patient about a side effect, you should know a 30-second message. It's a patient message that normalizes this conversation for patients. It has 6 points to it. You can say it in 20 to 30 seconds. You can make it your own. And that's what we do in our workshops for the care teams. They learn a 30-second message.
So give us an example.
Well, so what the 30-second message points are is that these sexual health side effects are common and expected. So in a situation where somebody has been thrown into menopause, you might say that the vaginal dryness is just one, would be common and expected. And we believe that that's a quality of life concern for you. And it is, even though you may not care about this right now, we know that studies show that addressing this sooner versus later will make a difference in the outcome. And we have resources to help. And it's appropriate for you to bring your questions to us. It is a medical issue. Sexual health concerns are. I gave you 6 points. There's a million different ways that you can say that message, but it's really making sure that patients understand that this is normal, to be expected. Talk to me about it. We have help. And don't talk to me about it in 2 years, because with pelvic radiation and other treatment too, but specifically pelvic radiation, definitely needed that addressed before 6 months after treatment, which was my problem.
So again, the 6 points are normalize it.
It's common and expected. It's a quality of life concern. It's a medical issue. So we have resources to help. And though you may not care about it now, addressing it sooner versus later makes a difference on the outcome.
Yeah. And so that creates this openness to communicating. And as a provider or a nurse, you come across as being understanding and are a willing, good listener who also has means of helping to make the situation better.
And oftentimes the patient, what they do in the workshops is we teach them a lead in line and an exit strategy. So a brochure possibly is an exit strategy, but the patient may say, okay, thanks for that information, or they may be emotional, or they may push back and say, I could not care any less about that topic right now. And that would be very normal. And that's okay. We don't expect, and I wouldn't care about it either, would be an appropriate response. I'm letting you know this now because you may care later, right? Life is long. You're going to survive this. And on the other side of this, you might want your life back. So I bring it up to you now so that you can bring it back to me if you do have concerns in the future. There's nothing but good in that message for the patient.
You're right. And as you said, it's a type of conversation that we have on a regular basis with other side effects that don't involve sexual function, that we don't get all nervous about. How am I going to talk about it? I mean, when we talk about side effects of nausea or dry mouth or swallowing or, all of those other things that don't involve intimacy, we can talk about them without getting nervous and flustered.
That's right. And our training really, it isn't a question and an answer. We aren't asking for a questionnaire to be given to the patient. Actually, it's a 30-second message. So it really doesn't disrupt clinic flow. But if the patient did have concerns, they'd know who to bring it back to. And if they had concerns at the time, you could get them an appointment with an advanced practice provider. And, from a business perspective, oftentimes that does work in clinics for an advanced practice provider to speak with the patient because they can bill and be reimbursed. So it's that model works too. So we have a course for advanced practice providers that go deeper into what are some of those issues? What are the sexual health side effects of all of the common cancer treatments. And then how do we evaluate that? How do we screen for those side effects? And then what can we treat easily in the clinic? And what needs to be referred out? And then who are those referral sources?
And for people who don't know the term advanced practice providers, we're talking about nurse practitioners and PAs.
Yes.
So they're not the oncologists, but many oncology offices have nurse practitioners and PAs who can spend more time, and they also bill for their services. So it can be a business model that encourages more talk and communication. And then just to repeat, not every nurse practitioner, PA, or oncologist is going to know how to address every sexual issue.
Right.
So having within your own health system this list of people that you get to know and network and partner with that you can refer to. So a gynecologist who is an expert on female sexual health, a urologist who is an expert and really good and comfortable about talking about male sexual health, a pelvic floor physical therapist on your team who knows how to do physical therapy related to it, a mental health provider who knows how to address, couple intimacy issues, whether it is a solo mental health provider, a marital counselor, or, and this is where we have a limited number of these providers, a certified sex therapist.
That's right.
That's not a super easy, overabundant type of counselor or therapist that we have available.
That's right. And we do a lot of consulting really with how do you interface with those groups to know that is a good referral source. And probably the toughest topic is that mental health. Providers are a little uncomfortable just giving a referral to just anybody. And where am I sending my patient? So we help them navigate how they get choices. They send out and get videos that come back, little 3-minute videos that come back from mental health providers that say, here's who I am, here's the methods I use, the type of patients that I work with, whether I work with couples or not, here are my hours, I'm taking new patients. So this 3-minute snippet of here's what my practice is all about. And they put those together, and then the provider can look at that and decide, who am I going to refer my patient to?
So your organization actually goes out and talks to mental health providers and see which ones are competent, interested, and have the capacity.
We don't quite go there, but that is a great next step. But what we do is we work with the clinic, whoever that coordinator is that is in charge of it, and they tell us who in their community they wonder about. And of course, that's a quick Google search too that can be done. Sometimes people want to have an option of doing it through the telephone instead of just doing face-to-face visit. So all of that is taken into consideration, but we help them with sending out the emails of what are we asking? What am I asking to come back? And then putting that together. And it can be either provider facing for who should the provider refer to, or it could be a patient facing video where the patient looks at the recording as to the different choices.
So I mentioned that one area that there is a shortage of is sex therapists. What has been your experience in interviewing, talking to, getting to know someone with that moniker, that title?
That word gets used loosely in an area where there aren't many sex therapists that are certified. So what ends up happening is, on the topic of sexual health, couples counselors get very comfortable, like you said, talking about these topics. And so they don't call themselves sex therapists. So they're not necessarily working with the function of a sexual act with the couple. So that's a little scary to people. I don't think I want a sex therapist. I might want to talk to somebody or go to a counselor, but I'm wondering what a sex therapist does. That's a little concerning for patients. And so we often don't, we say the word, but because there's a tough, there's not much out there for, even in,
Right.
I think in our area, maybe a couple.
Yeah.
Yeah. So counselors get real comfortable on this topic of being able to help patients and their partners navigate all of those things that they can control, like the communication between the two of them on this topic.
Yeah. And then we tend to rely on the gynecologist and the urologist when it gets to the anatomical stuff.
Correct.
Yeah. And I would say that's the route we usually go, is counselors that are comfortable talking about marital counseling. And, I don't think you can call yourself a marital counselor if you're not willing to address conversations about sexual health. But then when it gets to as someone trained as a radiation oncologist who doesn't know nearly as much about anatomy and sexual function as a good gynecologist who specializes in that. I know I've got a really good gynecologist who is the go-to person, who is, on speed dial and can see a patient within a week and does a really good job. And the same on the male side with urologists.
Also true. And I really think it's important just to note again that communication is a big factor here in where partners and patients, they have trouble. If you didn't have good communication about things like, sex, I guess, if we're not talking to the person we're sleeping with about sex, and then you have cancer, that conversation doesn't get any easier. And, to say the least, it gets very difficult. And the dynamic of that relationship changes. And then it's kind of a slippery slope. Once I don't think he's attracted to me anymore, and I change my behavior because of that, and he sees that as something that suggests I'm not faithful, it just goes from there without communication that is healthy, regular communication. And if you didn't have that going into cancer, you probably don't have it afterwards. It's people are just so helped by somebody helping navigate those tough conversations.
So let's talk some more about where you are with your organization. And I know there's a couple of different names that you use. One is After Cancer.
Yep.
And then the other is All of Me.
Project. Yeah.
So maybe explain what After Cancer is and what All of Me is, and where's your sweet spot right now, and what would your hope be with your organization 5 years from now?
Okay. So After Cancer is the company, and it's now a nonprofit organization. Before it was a coaching business. And so After Cancer is the company. And when we started this work, we applied for a grant and we had a name to the project. And the project was called the All of Me Project. So that's the differences in the name. And thanks for asking that question, because I think people do get a little bit confused by that. What we offer are courses and workshops for the care teams on that 30-second message to normalize the conversation is one. And then for those nurse practitioners and PAs on how to address sexual health and evaluate, treat what they can, refer. It's not. So it's a longer course. All of it being accredited though. So all for continuing education credit. So those two services and that workshop, we are turning into an online course, but right now it is given live or through Zoom. And then we also have patient educational materials, and they are for providers to either purchase for their clinics. And there are 20 different topics that help patients navigate intimacy after cancer treatment. And we just recently added a digital download option. So instead of ordering hard copy printed material, you can, for a period of time, 8 months or 12 months, you can have access to all of the library of patient educational materials for $1,500 or $1,800, depending on how long.
And that would be intended for clinics to do that.
Mm-hmm.
What do you have for information that patients can have access to? Can patients through your website access?
So patients through the website can read all of that information, and we're just now starting to provide on the website resources. Because we're not patient facing as a company, we do want to provide patient resources, though, where we can, because we work with so many other groups that do provide services for patients. So we just recently have started to add those groups that want to be on our site for the adolescent and young adult cancer patients. So we're adding those. We have a resource on our site that, under patient resources, that you'll pull up a PDF document that lists just hundreds of organizations across the country in alphabetical order that are patient supportive links, websites.
And patients, can they access and read free of charge the patient brochure on your website?
Yeah.
And what's the website?
It's aftercancer.co. So www.aftercancer.co, not com.
Yeah. And so what is that .co?
Well, .com was taken. So it was just just a domain name.
So that's a domain name that works.
It's like net or US or whatever. Yeah.
Because you're the only website that I
know
have in my list that's .co, not .com. Okay. So that would be a resource. So obviously you're focusing mostly on the providers. And so great brochures that providers can either have access to print themselves or can order to hand out to their patients. But patients can actually go on and read them.
They can. And we very deliberately are a provider-facing organization. And the reason is we have a strong belief that this work is for the provider with their patient, not for us with their patient. It belongs there, and it's why we provide the education for them.
Okay. Let's open it up for questions. So we've got a live studio audience here that will get first shot at questions. And then if you're watching this live streaming, you can put your questions in the comments section of the software that you're using to watch us.
A quick question here. And correct me if I'm wrong, but I'm thinking that what we're talking about today is much more important than most think. Patients might think, practitioners might think, and it's because sexuality is so important. It's such a huge, maybe the biggest component of the individual. So I could see where a cancer patient would say, well, I don't care about, my sexual health is like number 87 on my list right now. But if you want to overcome your cancer, it might be much more important than anyone thinks, because it is who we are. I mean, I don't want to go all Freudian, but you know what I mean?
I do know what you mean. We're all sexual beings. So wanting to be treated as such, feel like you are, is just human. We don't give any conversation to it in the clinical setting, or we haven't done much of that, is the only thing that's missing. It doesn't change how the person feels and what their needs are to have that intimacy in their life. And we aren't just talking about physical intimacy, sexual intimacy and physical intimacy. It's emotional intimacy too that is impacted by this. And all of that makes up who we are as a sexual being.
Okay. Other questions? So while we're waiting for any other questions from the audience, I'll ask again, where do you see your organization going? Where do you think you've had the greatest positive impact? And how would you like to have more positive impact on a broader scale going forward?
Wow, great question. If I had my way, every oncology clinic in this country would have their care teams trained on how to normalize this conversation for patients. So just quickly know that 30-second message and be able to refer patients to where they need to go when they have a concern. So I believe it should be a standard of care. To do that, I think we have to do more aligning with and partnering with national organizations that can have that be part of the guidance or part of the recommendations that clinics do with their patients. So we have a lot of work to do to be known.
What about having it be part of curriculum for, medical students or nursing students or PA students or nurse practitioners?
Yes, for sure. I mean, it really would be the ultimate is, as you think about this, sexual health, when it ever is discussed, it's kind of part of survivorship. It gets put way at the end of cancer. It's in survivorship. What national guidance tells us to do is get it moved up into right after the diagnosis. In order to do that, people have to be trained or feel comfortable on how to do that. The best thing that we could do is train people while they're being educated in nursing school, in PA school, to address it there where they feel like it needs to be addressed too. So being part of the curriculum would be wonderful. I have approached the University of Iowa College of Nursing for this to be a part of a course, a mandated course that they had to take. But I have to get in front of the dean to really, I haven't gotten in front of the dean yet, but have said as soon as this course is over, someone was going to do that. But that is important. I speak to the PA school at Des Moines University, and when you're talking to those students, they are so they're agreeing that
makes so much sense.
Yes. Why wouldn't you talk about this now? It makes so much sense. And so it's really, that's where I believe it needs to be, is there. Instead of us going out and training all these people after they've been in their field for their craft for so many years, it really should be in school.
And you probably need it both places. Because it needs to be normalized, and you don't actually truly normalize it till you do it several times. I mean, as a provider or as a PA, as an NP, where you really feel comfortable just bringing up, because you know how to do it, and without getting nervous and cautious, and you just become normalized. The first time you do it, you'd feel totally opposite of normalization.
Yeah.
It feels abnormal.
As people tell me though, after they go through the training and they do it, they give their 30-second message, and then we, meet later. They say, "Oh my gosh, I was so nervous to do it." And then the patient said, "Wow, nobody's ever talked to me about this before. Thank you for saying something about," and they have this deeper level of connection now with the patient all through that one 30-second message. It really is quite amazing to them, or so that they have told me, that they gain confidence in that. Once you hear a patient say thank you for saying something nobody says, it helps with your confidence, and you have the knowledge. So that's what you need.
Are you still doing your coaching, your more general life coaching for cancer survivors?
I do. I don't advertise that probably so much, but I do. So when patients do contact after cancer and just want to talk about their concerns, their own story, getting advice about maybe who to call or who they should be talking to, I do in that way. And I also do it for an organization called One Village So a platform for organizations to kind of employee assistance platform. I do sexual health coaching there.
Okay, great. Any other questions? Yes.
So do you think radiation oncologists should really bring up the subject? Because is Dr. Deming would know about this. I would think the radiation is what's causing, for example, like yours. Like,
Yeah.
your
And the
issues.
answer is yes, especially when the pelvis is being treated. Definitely, those are things that radiation oncologists are trained in, knowing that. It's another thing. Probably in departments where there's a specialization and the same radiation oncologist is doing the pelvic radiation, it gets a little bit more comfortable and commonplace and normalized in the conversation. So the answer is yes. Some of the other issues when it comes to the sexual function issues related to the chemotherapy or the anti-estrogen therapy, you know, I think probably the way it works is the radiation oncologist is thinking, well, that's the medical oncologist is giving him that treatment. That I don't want to step on their toes. They need to address that. In reality, we all are a team, and sometimes the person who should be isn't the one who is the most comfortable or maybe the most skilled at doing it. So the more that everyone is taking care of the patient, it's all of me, it's the entire patient, it should really be addressed regardless of whether they're being seen by the gynecologic oncologist or the colorectal surgeon or the medical oncologist or the radiation oncologist.
The cyber knife, is that something that's used for
So,
radiation?
yeah, so
in
CyberKnife
that
is a form of
area?
radiation that gives very pinpoint treatment, and that's generally used for treating very small tumors, either in the brain or the lung, or maybe just a lymph node. But that form of radiation is typically not used for treating rectal cancer or gynecologic cancer. Now, it can be used for treating a prostate. So that form of radiation to the prostate may cause fewer problems with erectile function in men for prostate cancer treatment than using a larger field where you're treating more of the pelvis that might include the nerves and also the lymph nodes. So yes, limiting radiation to different aspects of the body can help prevent sexual dysfunction. But if the man is getting anti-testosterone therapy as part of it, then that's going to have sexual dysfunction, even if you're using CyberKnife for the radiation. Any other questions? Well, we are at the end of our hour. This has been great. Thank you, Erin.
Thank you.
Really
for having me.
appreciate you being here. If you know someone that would benefit by listening to this over again or for the first time, it's going to be available on demand beginning tomorrow on the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. And again, the web address for accessing Erin's information on the web is www.aftercancer.co.
Correct.
Did I get it?
You got it.
Okay. So thanks for joining us. I hope you join us again next week. Thanks, everyone.